I'm gonna go ahead and get things. Thank you, thanks, Doc.
Sure.
I'm gonna go ahead and get things started, and I'll just say that it gives me great pleasure to introduce uh, Dr. Susan Rashid. Um, this whole idea was her brainchild when she was at the Nova Southeast and doing her medicine fellowship, uh, and uh, she was running these every week with great success, no CMEs attached, and we have not been able to reproduce that success despite the fact that we're awarding CMEs for it and at some expense to the college. But at any rate, I give Susan full credit for this idea. I ran with it after chatting with her and making sure that she would not be offended. No, indeed, she was happy that we were rolling with it because she wasn't able to do it herself. And I'm uh, I'm happy to introduce her. She has experience at the ICE unit, and I will let you introduce your many hats for yourself around social media, blogging, vlogging. I'm too old school to even understand some of this stuff, but I want to learn more about your career and your current interests, and I'm really interested in this case report from ICE. So I really appreciate your being here to do this, Susan. And I'll just say that these are being recorded. They are not just for posterity. They're on our website and available for CME for the foreseeable future, free to members and at a slight charge to non-members. And they are the property of the ACCP, excuse me, and can't be used in any way without the express permission of the ACCP. We give the CME credits quarterly, and all you have to do is announce yourself to Christine at accpmed.org in order to get the credits, but they are awarded quarterly. And without further ado, I've talked too much already. Go ahead, Susan. And I appreciate your being here. Thank you.
Thank you, Mike. Hi, everyone. Good evening. I'm so glad to see all of you today. Mike, for such a lovely introduction, and you're doing a really good job with ACCP Grand Rounds. When I was doing the journal club, that was like I was doing it every week for 2 years, so it was just a different time period in my life, but you're doing a really good job, and I'm very happy that you've taken this and you've continued on with it. So I wanted to share that with you, Mike. And so thank you for giving me the opportunity to present this really interesting case study I had with an ICE detention patient. So without further ado, I'm a family medicine doctor. I'll introduce myself a little bit. I am a family medicine physician. I did do the correctional medicine fellowship program with Nova Southeastern with affiliation with Centurion Health, and that was from 2019 to 2021. And then I got to meet all of you guys in the journal club. I would send out notifications of that every week. We would always have an exciting topic. And then I've been working in behavioral health hospital setting affiliated with ICE detention healthcare. And I'm also doing a lot with addiction and family medicine. And so I'm doing a little bit of everything. And also I'm working with Harvard Medical School and becoming a medical educator and becoming a social media and medicine specialist. So that's a little bit about me. Let's go ahead and proceed forward into our introduction of this case study. So as we know, in the United States, we have this crisis of mass immigration, and we have detention centers for people who don't have status in this country. And the United States is home to the world's largest immigration detention system. So this immigration detention system and how it works in the United States is that it is legally classified as civil rather than criminal, and it's not meant to be a punitive, it's not meant to be punitive, it's non-punitive. We have 7% of the United States population, or 22.8 million people, are not citizens in this country. And in 2017, about 260,000 people had either sought asylum or protection from persecution within the United States. So as a result of that, because we're physicians and we have to deliver healthcare services to people who are incarcerated, and in this case, these are people who they're incarcerated not because they committed a crime that is considered, like murder or kidnapping or what have you. The crime is that they don't have status per se. And so we still have to see patients that are in the ICE detention system based on our United States Constitution. So, but what this case study is about implicit bias. And that's really been a factor in our healthcare setting. And it's also been something that educators and organizations have been trying to be mindful of in when we're treating patients, especially patients that may not speak the same language as us, may not come from the same status or the same level of they're not from the same country, or for instance, in this case, they don't have the resources to seek out medical care. And here they are, they're showing up, and they also have a psychiatric condition. A lot of these ICE detention patients I've taken care of, they have some behavioral health issues. This can create an environment where they become very vulnerable, and it can create a life-threatening consequence for them. And so that's what I'm going to get into with this case study. We had a 40-year-old Hispanic male patient who had a documented history of multiple suicide attempts, depression, PTSD. And so the ICE detention facility had sent him over to the behavioral health hospital involuntarily for further treatment of his psychiatric issues. At the time of his admission, he denied having any suicidal, homicidal ideation, auditory or visual hallucinations. He did reveal a headache that it was persistent on a daily basis, rated at a 6 out of 10, and it was located on the left temporal region, and it was for quite a long time. He wasn't very specific about, was it a month or 2 months? It's just been ongoing. He did admit to nausea, vomiting, and dizziness, but he denied any visual changes, ringing in the ears, difficulty with ambulation, or any numbness and tingling. So now, in the behavioral health hospital, they have the psych residents and the psychiatrists do a psych evaluation. Then they have me, I'm the medical doctor. I come in and I give my medical history and physical, and I delve further into any of his medical history. So when I discuss further with him about the headache and what is this headache where was it stemming from? It had to have just come from somewhere. You don't just get a headache because, his blood pressure wasn't high or anything. He started opening up more, and he started saying that he had actually suffered a fall 2 weeks before he tried to intentionally jumping off the second tier of his dormitory, and he apparently landed on his head. So before he came to this behavioral health hospital, he had jumped off his dormitory on the second tier, and he landed on his head, and he didn't lose consciousness. And mind you, I went through the whole medical record of what happened in the previous ICE detention facility and what brought him here, and there was none of this really explained about him falling and jumping off and running for his life. None of this was there. So I'm listening to this, and this is the first time I'm hearing this. And the psych residents had told me that they also got some, notification from him that, yeah, I fell, but he didn't make a big deal out of it. And they wanted me to go further into, well, what was this fall about? And what is this connected to the headache? So he's telling me the story, and it sounds really sensational. How you just jump off, the second tier of a dormitory and land on your head and you're still here. But, I, kept listening to him. And approximately, he did mention 2 days after he tried to commit suicide, he did have some bilateral tingling and numbness. And he said it was like a electric shock like pain. So we have behavioral issues. Then we have an episode of where he's running for his life. He did tell me that the officers were running after him, and he decided to jump off from the second floor, and he landed on his head. And none of this is in his report from the previous physician in the previous setting that he was at. So he did report syncope, dizziness, shortness of breath, palpitations. They did, he did some evaluation at Colorado before he was sent to Florida. But again, there was no records of any imaging. The doctor from Colorado didn't write a whole lot about this obscure fall and about, why they sent him over here. It was just it was very minimal information that I had in my hands and that the psych team had in their hands. So he did report during the history and physical to me that he remembered when he was at the emergency room in Colorado after he jumped off the second floor of the building, that they did a CT scan, and they said to him there was some abnormality in the CT scan, right? But he doesn't remember what that abnormality was, but there was something wrong. And again, there was like 500, there was a lot of pages for me to read, but I went through every single one of them with the psych resident, with the medical director, with the psych medical director, everybody and their mom. I'm not finding the CT report. Either I'm going to believe my patient. I think we should believe him, but I don't have anything to connect this, that what he's talking about is not matching the medical records that was sent with him to this behavioral health hospital. Okay. So I decided just to send him to the community hospital, go to the emergency room. We'll just get a CT scan of the brain. At least I did my part. I'm going to believe my patient because this is my patient. I'm his advocate. And he's telling me he jumped off at the second floor of the building. He landed on his head. There was an abnormal CT. He tried to commit suicide. He's running for his life. I don't have anything from Colorado's Immigration Detention Center. I'm just going to send him to the ER and let's just see what the CT scan of the brain says. What's the worst thing that's going to happen? It's a clean CT and there's no problem. And then they'll send him back and it's like, all right, well, that was a fantastic story that the patient put me through. Well, let me tell you, when you went to the community hospital at the ER, they did a CT scan of the brain. They ordered that with and without contrast, as well as an X-ray of the lateral cervical spine. And the CT of the cervical spine was ordered. Now, the CT of the brain, it did not show any evidence of intracranial hemorrhage or a midline shift or a mass effect. However, it did show a likely chronic appearing injury of the left side of the lacrimal canaliculus, and there was some injury to the left side of the maxillary sinus and the infraorbital canal and opacification of the lacrimal groove. So there was some sort of chronic injury in the left side of the brain, which is where his headache is coming from. Okay. Then we go to the CT scan of the spine. Sorry about that. CT scan of the spine and the X-ray. This revealed multiple fractures of the anterior spinal column of multiple levels, including C3, C4, C5, and C6. And then among those fractured vertebrae, the C4 fracture is comminuted with involvement of the left vertebral foramen. There was no involvement of the posterior column. So the CT scan of the cervical spine did reveal that he had multiple cervical fractures. Okay. Neurosurgeon was immediately consulted and they recommended fall precautions, steroid therapy, and they wanted to do some further imaging with MRI to rule out any vertebral artery injury and lumbar spine injury. So after neurosurgery got involved, they not only started ordering more imaging, they transferred him right away into the intensive care unit for closer observation and care. And they placed a cervical collar for the patient and they watched him in the ICU for a few days before he was stepped down into the medical surgical unit. And then he was at the hospital for about a week, and then he was medically cleared and discharged back to the behavioral health hospital to continue his psychiatric treatment with the cervical collar. Okay, so discussion. One of the most critical components of this case is that there was a role of implicit bias that played in the delay of care for this patient. And here's the thing, in Colorado, all of this had happened, but yet none of this was, excuse me? Oh, okay. Um, so none of this was really addressed in the Colorado detention facility. They didn't send us any medical records. There was no appropriate handoff. There was no imaging that we could compare this to with what they did in the Colorado healthcare system with their hospital. And, it was just kind of like this patient was seen as a troublemaker. And because he was suicidal, jumping off a building, it's like they just punted him to a psych hospital that would be willing to take care of him. And they didn't want to deal with it. And so this was like a good learning lesson, especially for us in that, this patient has a psych history. He's a poor historian. His story wasn't making a whole lot of sense. English is not his first language, and he's in ICE detention custody. So he's got like 4 or 5 things that's going against him in getting quality healthcare services and having access to it and having good service provided for him, essentially. So it is reasonable in this situation, I suppose, to suspect that there may have been a fictitious presentation of his injury. He may have desired to find a reason to leave his environment of incarceration or permanently transfer from his detention care or detention center. But nonetheless, critical steps were not taken in the care of this patient. And it's so important that we as physicians, we've got to follow protocol, especially in cases of possible trauma, regardless of what language, what legal status you're at, what psychiatric issues you may have. And I think that that's really that was like a big learning lesson for all of us, and I know that the medical director and the psych team had asked me, why did I choose to believe him? Because they didn't think to send him to the emergency room to get a CT scan of the brain and the cervical spine. And that was something that they'd asked me, what made you believe that he actually jumped off 2 floors and he landed on his head? And that was something I honestly, why wouldn't I believe my patient? Even if he is, possibly having schizophrenia or a psychotic episode or whatever it is, why would he lie to me about, because it was so detail oriented. He was like, I did a CT scan in Colorado and they found something wrong, but they did nothing about it. And I have headaches that isn't going away. So, okay, why wouldn't I believe that? Why shouldn't we believe that? Why should I judge him because he's incarcerated in an ICE detention setting? He doesn't speak English. He, may have some behavioral health disturbances or behavioral health disorder. Why shouldn't I believe him? And that was really it was really lovely. Like all the psychiatrists and the other doctors, family medicine doctors are like, yeah, that's right. Why shouldn't we believe our patients no matter what? And so we always just have to be our patient's advocate and really try to curb this implicit bias of our patients. And so that was a big discussion about that. And here we go, a misdiagnosis of cervical fractures for the duration of 2 weeks. This is not acceptable outcome in any circumstance. I mean, this could have actually led to a litigation situation had this not been addressed in that behavioral health hospital accordingly. And even though Colorado or whatever they did in the other facility, they didn't do their part, at the end of the day, when you accept a patient, you take responsibility for that patient's health and their healthcare needs. And so, we just have, I guess we're just very nice doctors, us correctional doctors. We're very nice, we're very benevolent, we're very patient. And the other clinicians that haven't dealt with incarcerated populations, it's like a kind of like a, wow, we do have to be nice when we take care of patients. And so that was really it. This is a unique population. They have unique challenges. It's so important that we always meet the standard of care and that we as clinicians, we do what's ethically right by our patients. And so in conclusion, we have to deliver and improve the standard of care and make sure that the care is ethical and its quality, and that regardless of their background or socioeconomic status, and again, this is a classic implicit bias that took place due to a language barrier, psychiatric condition, and ICE detention status, and we should not, you know, you know, even if we do make a mistake, we have to learn from our mistakes, right? And so instead of shaming or blaming other providers, I was a little angry at Colorado and how they handled the Colorado doctors there, how they handled this case. But again, I can't let that continue to, keep me from practicing good medicine. And, we did call them the Colorado detention and we let them know that they really didn't do like they could have done a better job and they need to be mindful of this in the future. But these are things that are evolving, that we really curb this implicit bias, especially for this population group. And that's basically my references, and that's basically it. If you guys have questions, I'm happy to take questions. I'm happy to have an engagement and a discussion about this really interesting case. And yeah, I am gonna leave the microphone to the audience now, and I look forward to talking and hearing from you guys.
So I've gone ahead and taken myself off of mute, and I suggest that anybody who wants to make comment should do the same, and or use the chat to discuss this further. I think that so we had this discussion about a month ago with Steve Shelton, who presented on the fundamentals of ethics, and I think that what you're saying is that this was a case of failure of beneficence, and maybe due diligence. I think so. So one of my questions when you told me about this case and when we were planning this was, what about the culture of the institution, and how does that relate to the care in this case? And were you able ever to track down any emergency room records from Colorado? They just didn't come. If he went to the emergency room, which presumably he did, that continuity of care was absolutely missing because they didn't send them along with the patient. So there's questions of continuity of care and beneficence here. And Steve Shelton has unmuted, so I'm ready to listen to him too. But
thanks. There were a lot of red herrings in this case, and I'm really glad you brought it up with us. I think there's probably every one of us has seen, heard of, or run into a case somewhat like this, where someone finally takes a deeper look somewhere down the line and says, oh my, this person does have a problem. The patient who's always complaining of back pain, and then I get a call in the middle of the night saying he says he can't stand. What am I going to put? The person on site says, what should I do? And I said, well, go see if he can stand up. He can't. We go down, big, massive abscess on his lower spine. And there are others like this. I think that I really want to thank you for bringing this up, because it's a reminder that all of us, at any time, even the best of us, can forget to look anew, and that sometimes we have to look again. And so, it's trust but verify. And sometimes you don't trust with no verification and no reason not to trust. So trust but verify. And I think that it's also very useful. One of my teachers once said to me, the first time you see a patient is when you're going to do the most thorough history and the most thorough physical. I think if you still have somebody who's complaining of something you don't understand a month later, you do the whole beginning history and physical over again and see what you might find. Thanks for listening.
It's a great job, Susan, picking that up. And I too was curious about it almost sounded as if the Colorado place didn't send them out. but I guess you're saying that he did, that they did, and that an ER missed this, which is pretty surprising, I guess.
Yeah, we just don't know. That's the problem.
Right.
All
I
right.
had two cases that I think are sort of very similar to this. One was my first week as a site medical director in a prison. I it was, it was the first day going into the infirmary and making rounds in there. And there was a patient, Native American patient who I'm not sure that's relevant, but it was a Native American patient who I just couldn't figure out why she had belly pain. Her stomach bothered her. I examined her. It was a little tender. Her labs were all normal, and she'd been handed off to me. She'd been there for a couple of days, and I looked through a chart and examined her, and finally, 3 or 4 days into this thing, I just was thinking, maybe this is just, that she wanted a couple days in the infirmary or whatever. But I realized, hey, nobody ever did an X-ray on her. So we did an X-ray. Again, this is my first week in corrections. We did an X-ray, and she was completely filled with tacks, upholstery tacks, her stomach. And I went back to her and I said, hey, how come you didn't mention the nails to me? And she said, what nails? So that was certainly a good introduction in my first week. And then a couple of years later, I had another patient who had chronic back pain, just the way Steve was just saying, or Mike, I don't remember which, I think it was Steve, that just had this chronic back pain and complained, and it was lumbar, and your typical, maybe doesn't want to work, what is going on? Full neuro exam. I did a full neuro exam. She was another provider's patient, and so I had that NP do a neuro exam, and we followed her for a couple of weeks, and she just wasn't getting better, and tried all the routine things, and she's just, my back is just killing me. And I really felt like she was just not, I didn't believe her exam was so benign that I didn't believe there was anything wrong with her. We got x-rays on site, they were negative. Finally, I called the regional medical director and said, and I was working at the time for a private health, for a contracted healthcare company. And I called the regional medical director and said, I know that we don't want to send people for imaging that, for an MRI that are, without having some neuro findings, something to make, but I got to send this woman just to prove to her that there's not, which obviously has great risk to it, but just to prove to her there's nothing wrong with her. And I know, of course, there's so many, things that we find that are little minor things that get reported, and it was really a risk. And so the regional medical director said, okay, we'll go do it and take that risk. And she had a big cervical epidural abscess, and her pain was all lumbar, big cervical epidural abscess that I left for 2 months. She had no fever. She had nothing except her white count was normal, except this lumbar pain. So I had documented all this, as well as I could have. And the way I found out was the radiologist called me and said, oh my God, you got to get this patient in the emergency room right away. So she wound up with 2 surgeries and was really sick in the infirmary. I took care of her there. And, I told her that, we did everything we thought. I don't know when, or it's been a few years. I don't know when or if I'll get sued, but whatever it was, I guess she felt like we were paying attention to her at least. But I sure missed that one.
I think we all have something like that, or one of the people that we're supervising has done something like that. It is very common, and it is part, I think, of medicine. I've come up with a risk strategy that I kept when I was medical director. I kept telling all my docs to practice, and that is you take the disease and you practice from 2 ends. And one end is what's the worst this can be? What do I need to prove it's not something bad? And the other side is, what's the most likely thing this is? And then, you sort of work those two until you're comfortable that you've hit the middle ground and found nothing. But you have to work at instead of saying, I'm going to find a diagnosis. I think it's more proper and safer to say, what's the worst this could be? What's the most likely? And work both those ends until you find a diagnosis. Don't just work one end. That's also having watched many expert witness cases.
Right.
It's a good reminder. It's a very good reminder.
So just to add to your comments, this is Mike Nikki. I usually work in ER too. Still, this is the largest settlement that we are giving out right now. The missing epidural abscess, and typically you just have to suspect there might be no neurological. As I agree with the case that Seth presented. Just yesterday, I had a shift in ER, and we had a lady that came in, 41-year-old. This is a third visit from jail. And neurology and our colleagues in internal medicine blow her off a couple of times before, malingering. So I insisted doing a gadolinium MRI yesterday, and we picked up MS as a diagnosis. And she got admitted. Everybody was passionate about the patient suddenly. So you have to insist. If it doesn't look like a typical thing, just to stand back and open your mind, look for something you could miss.
We get weird stuff. And this is, I just have to interrupt you. I have to jump in for a second. That's why we think this is a specialty, because it is a unique population. It is a unique set of diseases. Not unique, but the likelihood changes. And, when you're in Africa, you do look for a zebra. When you're in Wyoming, you look for horses. When you're in the tropics, you look for tropical diseases. We have correctional diseases, and you're quite right. Those abscesses are very common in our population, and they're not in the outer population. So people on the outside miss them all the time. Off my soapbox. I'm muting.
Well, I'd like to go back to the culture, and we can only hypothesize about what went on in Colorado. It sounds like you actually tried to contact the medical director or somebody in Colorado to talk over the case and give them feedback on that's a very difficult thing among colleagues, and especially among colleagues that you don't know or trust. And I commend you for that. But it's hard to decide what happened without more information around the culture of what happens when somebody jumps from the second tier and hits their head. Is there a big commotion and 911 call immediately? Is there what goes down? And you obviously had little to no information, but it feels like at some point they sent him to the ER, but no big deal was made about him crashing and burning like that. And that really does speak to the culture of the institution. And I think it's a really important piece. I'm working with an institution right now that the culture of the institution is refusals. Everybody refuses everything, and nobody bats an eye at refusals. And we're working on, well, that's not okay. I mean, maybe this is concierge service jail where nobody wants to do anything and they just want to sit in their cell. And I don't know what the deal is, but or maybe they just don't trust the medical staff enough to do good work. They just refuse anything and everything and wait until they're out on the streets to deal with problems because they feel that they're not treated. And so what's the culture of the institution, I think, is a key element to this question. And unfortunately, we hear you get some innuendo about ICE facilities. I mean, and I'm not going to ask you to go over a barrel on that, Susan. But on the other hand, I think that there's a certain culture of why are these people here? What are why do I have to deal with this guy's bad behavior? Whatever. And so the whole notion of this is not a punishment or a punitive setting, it sort of sounds hollow to me. And that's political. I get it. That's not medical. But this case speaks to that, where something happened and it was undiagnosed despite what sounds like witnessed major trauma.
Yes.
And that again speaks to the culture of the institution. I wish you'd comment a little bit about that and how you see that. So the culture at wherever you were working in this psychiatric facility was clearly different
Yes.
than
Totally.
than whatever the culture was at the other facility in Colorado. And I'd invite other people to join in, because I think that everybody has something to contribute to this conversation.
I was assuming on all my comments that you were in a good culture prison. And so I appreciate your pointing out that not all places are the same, and some do care about their patients and a lot of the doctors care about their diagnosis, and some places just brush everything off. So thanks, Mike. Open it up again. Comments?
Susan, I have a question. How did you manage to communicate with this person? You said he didn't speak English, and how were you able to get him to confide in you to be able to get in-depth information from him?
So hi, Michael, nice to see you. Thank you for your question. So I have a lot of medical assistants that speak Spanish. So the translation part I have access to that. That's one. But two, for him to really open up and have a decent conversation with me, he spoke broken English. And so I tried to be at his level. And I remember that when I did his history and physical, the medical assistant was by my side and we were translating. He was translating for me, and the World Cup was on. The World Cup was being played on the television set. And he was a big fan of football and soccer. And I played soccer when I was a teenager. So I knew, and I watched the World Cup. And so that he started feeling like he could trust me in a way. And I wasn't trying to do that to grab him to trust me. He was just in that setting. That's where I was doing my history and physical with my medical assistant. And when we were watching the game with Ronaldo from Spain, and Ronaldo's Spain, right? Portugal.
Yeah.
Talking about Ronaldo was Portugal, and I think
Yeah.
Argentina. Those were the two soccer players that were up against each other, and it was really exciting. This man is from that area of the world, Latino based, and so that was our connection. And so I, was watching the game with him as I was doing his physical exam, and that's when he started opening up about the episode that happened inside the Colorado ICE detention facility. It was not something he just opened up initially to the psych residents, to the psych medical director, to anybody else. So this was like an important piece of information that I wouldn't have gotten from sign off, from the medical reports, from the Colorado detention facility. This was just me doing my job as a doctor and just trying to, make my patient trust me and feel safe with me. And he was watching the football game, and I happened to know a lot about soccer. And then he started saying, so this happened to me in Colorado, by the way. I was running for my life, and that was it. Yeah.
Wait, so Susan, one of the things that somebody, again, I think it was Steve actually, had been going under the assumption that, this person had been in a good facility. And I'm looking at the assumption that this injury actually happened before, for whatever it's worth, before he went to the jail, and that it wasn't him to the ICE facility in Colorado. That especially if he was running for his life, something happened, he fell a very great distance and went into this place, and and again, with his mental illness. And so my question for you is, did you actually ever get to talk to somebody from the Colorado facility where they said this guy fell 2 stories and landed on his head?
They didn't say that. Colorado didn't say that. Colorado has no documentation of this. The patient said it.
Yeah, I have a
Interesting.
feeling, I mean, whatever it's worth, I mean, it's, again, I'm projecting my bias or whatever, is that I think he probably, especially because it was chronic. They said, I mean, 2 weeks, you're going to start to see some chronic changes, but they talked about on the findings that this chronic stuff going on in the bones and in the lacrimal duct and all that. So I wonder if he didn't have this happen before he went to the jail and they never really knew.
But then he mentioned in the history that when he went to the emergency room, the Colorado detention did send him. And mind you, this is what he said. They found something abnormal in the CT scan. He does not know what it is, but they found something that wasn't right in the picture. Granted, I have no evidence of this. I'm just going by what I have. A patient who English, who isn't, opening up to anyone, doesn't trust anyone, and he's sent here for behavioral health analysis for his suicidal attempts.
Right.
And so that's all I have. And had I not believed him, had I not went ahead and sent him to the community hospital to do further imaging, we would have ended up with a crisis with his cervical fracture that was not medically managed appropriately. So,
So they did say that cervical fracture, that the chronic changes were in the facial stuff, but that cervical fracture was fresh. Is that what they were saying?
They were saying that was fresh, and he went straight to the ICU right after they found that. Straight to the ICU, and they put the cervical collar, and neurosurgery watched him, put steroids on him, and really just tried to make sure that there was no, neurosurgical intervention that they needed to take him to the operating room, because that's very dangerous. They had to do an MRI to make sure that it didn't dissect the vertebral artery. That's the big thing that they were worried about. This was not picked up anywhere. So again, all I had was a patient. That was it, by what the patient said. And he was.
This brings up, sorry.
So
This brings up Seth brings up an interesting point. So here's the scenario to think about. He was running, he got injured, he got taken to the emergency room. They cleared him and took him to a detention facility. They didn't send any notes, just he's clear. So always be careful about what you get from the emergency room when you don't get anything from them.
Right. I think that's what happened. I think that's what happened, because I mean, there's lots of things that you see that you wonder, like, okay, so now there's reports from what's the jail, Fulton County Jail, where they're talking about somebody that died in the jail and the cause of death was starvation, malnutrition, electrolyte abnormalities, and infestation of rodents and bugs and stuff. And so horrible things can happen and be believable, but for someone to fall 2 stories and land on their head when there's other people around, I think we might be blaming, not you, Susan, you did a miraculous job no matter what, but maybe there wasn't a facility that did such a bad job, except for an ER that ignored the fact when whoever the arresting people were, they brought him in, clear him so we can take him to wherever he's going next.
One thing that, Susan, I think probably need to be looked at is the intake process at this Colorado facility. Because even though he may have been brought by ICE personnel from whatever, from the emergency room or from the hospital, they probably didn't do an in-depth review of this patient before even accepting him into their custody. Because somebody comes in and they hand him over to you, that is your patient.
Right.
And if the patient has any history of something that you don't have records of, you should send him back to the emergency room where he came from.
But I could,
Because somebody, I thought I might have heard about, he vomited, he was disoriented and all that kind of thing, which to me depicts of some head injury. And you're accepting him into your facility. Thank God he didn't even die that night, because I've had an experience with one playing soccer, got beaten on the field, nurse called doctor said send him to his room. Next morning he was gone. 2 million to satisfy family. And these things happen. If the assessment is poor, everything else is going to go down the wrong way.
yeah, I mean, honestly, they didn't send much of any significant value from the Colorado detention facility. I didn't have much to go off of. They just sent they sent paperwork, but nothing about his intake, nothing about how he presented when he first came to the Colorado detention. It was a lot more legal stuff than it was valuable for me as a practitioner in the medical assessment. There wasn't much value there at all. It was just kind of like, all right, he's just got to get out of here. He's trying to commit suicide. He's being difficult with us. We can't handle him. We don't have the resources. And so whatever happened when he went to the ER in Colorado and what imaging studies they did, I have no way to ever prove that it even happened or the subsequent sequence of how it happened. What came first? Did he go to the ER first, then he went to the ICE detention facility? Or did he go to the ICE detention facility and then he went to the ER? All I had was what the patient said. That was it. And that was it.
You guys mentioned a lot of things about the ER. That's where I live for 25. I've been in level 1 trauma centers. In the past year, we have missed 2 cases of CT angio where the patient upstairs is stroked out. So right now I'm working with 10 emergency room and hospitals around us by probably 10 miles, 15 miles. And each one of them treat patient differently as they're going. There's no standard. The common sense is those experienced attending at supervising the environment. You mentioned about the intake. If the nurse is not trained in trauma or emergency room in the intake, they're gonna miss it. That's what the problem is. So we have like nurses that come from psych background and doing intake. So there is a variability in patient's evaluation of patient care. What we did, like what personally I did, was every year I do 2 sessions of training for my nurses, review cases that are very critical to our operation, including trauma, abdominal pain, torsions, things that may be critical in a scenario. And just to put them on the notice, because we have obviously turnover, new nurses come in, get everybody on the same page, you examine and report, and then CQI is the best way to go. Review the cases, try to teach them. I know the big institutions are very difficult, but you can't rely on ER. Absolutely not.
Now, I'll just say that we were looking, one of the objectives for this was to look at the root cause analysis and look at what the root cause of this series of events was. And I think our conclusion was that we don't know, but except for the notion of continuity of care, which one of the root causes of this was there was no communication between one facility and the next about what was going on and what had gone on with this person. And that was key. Go ahead, Steve.
I have a root cause, not a root cause, a root solution that Susan came up with that is so basic when you think about it, it almost makes me giggle in some way. You know, SOAP, subjective, objective. You had no objective, nothing there. So just based on the subjective, you went and got objective findings. And that's a brilliant solution to whatever the root cause of no objective findings were. You had none. We don't know why you didn't, but at least you recognized you had no objective findings whatsoever to say he was well or not well.
Right.
Nothing. Zip, zero.
That's right. That's why I made that decision. Well, what's the worst thing that's going to happen? The ER doctor,
There you go.
why'd you send this patient over and waste my time on doing all these imaging studies? And I was ready for I was like, you know what? You had fun, that's it, and you move on. You know, that was the worst thing, and I'm willing to take that consequence. A doctor yelling at me, a colleague calling me, you know, your brain isn't working, whatever it is, you know, things we say when we're, you know, trying to be petty. But, you know, at least I did right by my patient. I believed my patient, and, you know, why would he make this up? Really and truly, what? He just wanted a trip to the ER and get some fresh air? That's all right, then fine, whatever. But the way he was expressing himself, I don't know. But that's the way I am. I'm like that with all my patients. I don't care what background you come from. I don't care what your status is. I don't care what language, whatever it is. You're talking to me. You're trusting your healthcare into my hands. I need to take, I'm honored to do it, and I'm going to deliver the best that I can with the knowledge and the expertise that I have. And that's, I think, that's how we should all practice. That's my belief system.
I don't think you have to convince too many people in this room about that. It's those who are not present that perhaps need more education in this, and we're going to try and figure out how to get them in here.
They're nice doctors. My correctional physicians tend to be very nice. We tend to.
I agree with you completely, and that's why I say that those in the room are definitely really good at what we do. And we see and hear about these other sort of nasty, bad outcomes, and we can't make judgments about them unless we're really able to have the objective findings of, well, what actually really happened in Colorado. We don't know. I think that Seth's idea about that was every bit as good as any other idea about what happened, you know. And so I don't know that,
Dr.
they did say there was a fresh fracture, so I don't know. Steve?
We did not mean to say anything negative about emergency rooms. My comment was not about what the emergency room might or might not have seen. It was about that there were no records. And that I see as a common theme. And that just goes back to, again, you had no objective in anything. And it's just, you know, it's so common that somebody will come back from the hospital and we got no information. And that's not the doctor's fault at the emergency room. That's their damn hospital policy.
Mm-hmm.
So I'll just tell you all, any more discussion? We're at 2 minutes, T-minus 2 minutes from an hour. And I think we've had a useful discussion all in all. And Dr. Niki?
Like, Susan, maybe you should write this case. It's a very good case for learning.
I will
education.
I'll definitely.
If you need help.
Oh, good. I get to make friends and have friends help me with writing. I'm so honored. Thank you.
I only need your patient's consent. Okay. If you have to communicate, and we could do that through our IFP.
Yeah. All right. Definitely.
Nice.
Yeah. Thank you.
So I'll tell you that we have the next 2 sessions are going to be really good, and spread the news to your colleagues and friends. The first one next in 2 weeks is Jeff Keller, who's going to talk about verbal jujitsu, how to communicate better with patients. And this is a great segue from both Steve's ethics talk, Susan's case, and going right into communication skills, particular to the correctional milieu, is going to be really helpful for us. And I really look forward to Jeff's talk. And then in 4 weeks, we're going to be having a nurse educator from UConn and a Psych D clinical psychologist and me discussing how to improve our quality of life in correctional medicine and our professional quality of life, and specifically around questions of um, difficult patient encounters and having the emotional intelligence to understand when our patients are making us crazy. And if we can understand these factors, I believe that we can do better care and have a lesser chance of burnout and problems with a very difficult career, a wonderful career. But correctional medicine is difficult, and if we can understand the way that we manage ourselves, I think we can do even a better job with patient care.